This conference will now be recorded.
So I think some of you have asked for a repeat of this class, stages of labor. So we're going to just brush through what we have already done before, but I think it's definitely very important because we are going to ask you in theory. It will come again in your clinics as well as in your Viva. So I think definitely every one of you must have an absolute hold on this point, this topic. So we're talking about stages of labor. So I think stages of labor, every one of you is aware that we have 4 stages of labor. So coming to each of these stages of labor, always labor will start with the onset of true pains, or what we call true uterine contractions, and end with the full dilatation of the cervix in the first stage. So before you start defining somebody to be really in labor, what do you think that the definition of labor contains? The start of painful uterine contractions associated with or accompanied by one of the following: rupture of membranes or a bloody show or a complete cervical effacement. Any of these things would mean that the process of labor has started. Now, to just make it very brief, the first stage of labor involves a stage of cervical dilatation. That is from totally closed cervix, where there is cannot even enter a finger into the cervix, still full cervical dilatation. That is 10 centimeters. That is the first stage of labor. In the second stage of labor, once the cervix is totally open, the baby has to just come out. The second stage involves delivery of the baby. The third stage, once the baby is out, what is left inside is the placenta and the cord. So the stage of separation and expulsion of the placenta is third stage of labor. And in the fourth stage of labor, once the placenta is also out, there is nothing left inside. It is the stage of observation. During this period, the uterus is taking utmost precautions to undergo hemostasis and put an end to the bleeding which is occurring from the open sinuses of the placental separation. So these are the 4 stages, and we'll go through each of these in detail. So coming to the first stage of labor, it starts with the onset of true labor pains and ends with full dilatation of the cervix. As you can see here, the cervix is closed, and as it progresses, the cervix opens up, and finally the whole of the cervix has opened up, and all the baby has to do is come out into the vagina. So what are all the phenomena that occur in the first stage of labor? There will be a beginning of uterine contractions, or what we call true labor pains. And how the true labor pains can be differentiated from false labor pains is due to its association with cervical effacement, which is the shortening of the cervix, and cervical dilatation, which is the opening of the cervix. So if these 2 changes are there, then you definitely label them as true labor pains. Now, when the cervix is closed, you know that the cervix is made up of a canal, which extends from the internal os to the external os. And that cervical canal is filled with what is called a mucus plug. Now, when the cervix opens up, it cannot stay there. That plug will no longer have a support. So it will be expelled in the form of what we call a mucosaccharinous discharge, otherwise called show. Now, also when there is no more support to the membranes which are surrounding the baby, they will form a bag of membranes. Hitherto the cervix was closed, so they were supported. Now when the cervix is opened, the bag of membranes is formed, which is filled with amniotic fluid, and a few more contractions and pressure will cause rupture of the membranes, resulting in leak of the amniotic fluid. So these are the main 6 events that take place in the first stage of labor. So coming to each of these in detail, what are these true labor pains? Here, every pain will start from the fundus near the cornual region of the uterus. So there is a fixed way that it starts. The uterine contraction of the pain starts from the upper end of the uterus and comes downwards. So there is a serial decrease in the strength of the contraction. So this helps in pushing the baby downwards. So what you call the pacemaker of the uterus, that starts at the cornu of the uterus. So at the cornual ends, it will start and go further downwards. And each contraction will last about 45 seconds. Now coming to this, the upper segment, the upper uterine segment is formed from the body of the uterus and is mainly responsible for the contraction and retraction of the uterus. So this part of the uterus, as you can see here, this upper part of the uterus is very thick and muscular, and it is mostly involved with the forceful contraction with which the baby is pushed down. Now when you come to the lower segment is otherwise what is the isthmus in the non-pregnant uterus. So this actually develops in the pregnancy. So the lower segment is nothing but the isthmus in the non-pregnant state. So that is very different from the upper segment in terms of that causes only distension and dilatation. It is quietly taking whatever is coming into it and not contracting. So lower segment is just prepared for distension and dilatation. It is taking up whatever is being pushed from the upper segment. So if you see this in a pregnant uterus, when it is not in labor, you can see that it is uniform. There is an upper segment, lower segment, but there is no well-formed lower segment. However, as the uterus contracts in the first stage of labor, you can see there's a thinning of the lower segment, thickening of the upper segment. And as more and more labor progresses, the upper segment contracts harder and harder, and it becomes more thicker. So there's a thick muscular upper segment and a very thin dilated lower segment. Okay, now to just differentiate between the true labor pains and false labor pains. So the true labor pains are progressive in nature. Very typically, the nature of the true labor that it will go on increasing in frequency, intensity, and duration. So how often it occurs? So how often it occurs, how intense it is, or how strong the contractions are, or how long they last. These are the three things you should take care of. So increasing frequency, intensity, and duration. This will be progressively increasing in true labor pains. However, in case of false labor pains, there is no regularity. Anytime, anyhow, with any force of contraction. So there is no particular rhythm. So the true labor pains are very, very typical in their presentation. Also in true labor pains, they will be associated with progressive cervical dilatation and effacement. Dilatation is the opening up and effacement is a shortening. When in case of false labor pains, there will be no such changes in the cervix. So when you do a pelvic examination, you find the cervix is closed and there are no changes. And also when you give them sedation or you give them an enema, in case of true labor pains, nothing can stop it from progressing. So whether you give sedation or an enema, it will continue to progress. Whereas in case of false labor pains, you give them sedation, patient calmly sleeps, or if you give them an enema, the pains will subside. So that is how you can differentiate false and true labor pains. And the most important thing, of course, when there are true labor pains, there will be a descent of the fetus. When you mark every time when you do a pelvic examination, you find there's a progressive descent. However, in false labor pains, there are such irregular contractions, has nothing to do with pushing the baby down, no changes in the cervix, so you will not find any descent in the fetus. So very typically, you must be able to differentiate true from false labor pains. Okay, now coming to each of these terms, what is effacement? So effacement refers to the thinning or the shortening of the cervix. So you can see here in an undilated, uneffaced cervix, this is the length of the cervix from internal os to external os. Now, as and when the contractions progress, the length of the cervix becomes smaller and smaller. So here is the internal os, external. So it has become shorter. Now here you can see there is no length of cervix at all. There is no length. It is totally flattened out. So here you will call it 100% effaced. So effacement is the shortening of the cervix. So what has happened to the cervix actually? The cervix has been taken up by the lower uterine segment. It goes into the lower uterine segment. So it is not that it is disappearing. It is taken up by the lower uterine segment of the uterus. Now, what is dilatation? So cervix effacement was shortening, dilatation is opening. So in the process of enlargement of the uterine os, the uterus becomes from a slightly closed aperture to a large opening enough to permit the passage of the fetal head. So you can see here, the cervix is closed. Here there is no opening. Now here slowly the cervix is opening, more and more opening, and finally the whole of the cervix opens up. So you can measure this cervical dilatation with your fingers when you're doing a pelvic examination, and depending upon the dilatation, you label it as uneffaced, undilated cervix to partially dilated or a fully dilated cervix when it is 10 centimeters. At 10 centimeters, you will not feel the cervix at all. There is no palpable cervix. Totally, the only vagina continues with the uterine wall. So that means the baby is in direct communication with the vagina. Okay, now you can plot the cervical dilatation in a curve, what is called a partogram. So initially we used to have called them the Friedman's curve. One of the original, when the partogram started, they used to plot the cervical dilatation against time. So you can see the y-axis is dilatation, x-axis is the time. So in the initial part, the dilatation occurs very slowly. That is what is called the latent phase. The duration is variable and very little cervical dilatation is occurring. However, once the patient enters into the active phase, there is an accelerated phase when you can find a sudden dilatation of the cervix, rapid dilatation of the cervix, where there is a maximum slope, and then it is followed by a phase of deceleration. It slows down its dilatation. That is the way the cervix dilates. So initial latent phase, then a rapid phase or rather accelerated phase, and then a phase of deceleration. What is show? So just at the beginning of the labor, a small amount of red tinged mucus may be passed. This is nothing but the cervical mucus plug. As I told you, between the internal and external os, you have the cervical plug, a mucus plug. When the cervix opens up, it no longer has a support, so it is expelled in the form of a show. Whenever the patient complains of passing this sort of a show or the mucoid discharge, you know patient has gone into true labor. It indirectly tells you the cervix is opening up. Right. Now, once the cervix has opened up, I told you the membranes will no longer have any support. So more and more contractions cause pressure on these very thin membranes, which are otherwise called amnion and chorion, and the fluid goes into it, and what is called the forewaters. Hindwaters is behind, forewaters is before the presenting part, and few more contractions in this thin membranes will rupture with the expulsion of the amniotic fluid. So that marks an end of the first stage of labor. So the duration of first stage of labor is, in a primigravida, it takes about 12 hours, whereas in a multigravida, 5 to 6 hours. So you can imagine if somebody is doing something for the first time, it takes time to get used to it, so it will take a long time. But when you have increasing experience, if you're doing the same thing again and again, you know you can do it faster. So the same thing here, primigravidas, dilatation occurs in 12 hours, multigravida in 5 to 6 hours. Now, once the cervix is fully dilated, that marks the end of the first stage of labor. Membranes have ruptured. So now there second stage starts from full dilatation of cervix to expulsion of the fetus. So the second stage is basically expulsion of the fetus. Now it is easy to imagine that once the cervix is dilated, all the baby has to do is crawl out because it's fully open and the uterus is continuous with the vagina. So there is nothing in the path. So you can think that the baby can just crawl out or just fall down if you make the patient stand. But however, it is not so, because the passage is very small. The pelvic cavity, as you know, is very small, very narrow, and it is filled with soft tissue. There are muscles, there are organs like bladder in front, rectum behind, and the whole thing is covered with tissues. So you don't have such a big passage that you can make the patient stand and the baby will fall down. So in other words, because the cavity of the pelvis is differently shaped in different levels. At the inlet, it is transversely oval. Cavity is more or less circular, and outside below the ischial spines, it is anteroposteriorly oval. That means the shape of the pelvis is changing at different levels. So the baby cannot just go in a particular direction. It has to go along the direction of the largest diameter of the pelvis. So it undergoes when a lot of cardinal movements, what we call as mechanism of labor, before the baby can come out. So second stage is the stage of expulsion of the baby. So here, the nature of uterine contractions become very strong and severe, and this leads to a bearing down effort. The pressure of the baby itself on the pelvic floor also stimulates the voluntary muscles to contract. The abdominal muscles are also contracting, and the fetus is pushed down through the cervical canal. And once the baby reaches the perineum, and it stretches the perineum to such a stage that even between contractions, that is, even when the uterus is not contracting during the phase of dilatation, the baby can still be seen at the introitus, and that is when we call crowning. When the baby's head does not recede during dilatation, that is crowning. And finally, the head passes out through the outlet. So if you were to see a series of movements, so all of you must remember the series of movements, what is called engagement, descent, flexion, internal rotation, extension, restitution, and external rotation. So, and expulsion. So these are the various different kinds of movements that occur as a process of mechanism of labor by which the baby comes up. So each of these steps, all of you must know, and the simple mnemonic is Ed Fieri. All of you must be knowing that to remember the series of movements. So coming to each of them, engagement. Engagement is nothing but the largest diameter of the head enters the brim of the pelvis. So here you can see that this is the biparietal diameter between the two parietal bones, one parietal bone here and the other on the other side. That's called the biparietal diameter. That has entered the brim. Brim is the inlet of the pelvis. So once the biparietal diameter enters the inlet of the pelvis, you call it engagement. Next is the descent. With each contraction, the baby goes further and further down. So in the absence of any cephalopelvic disproportion, if there is a nice space which is enough for the baby to come out, the head will descend further and further down. And in fact, this process of descent occurs throughout the process of labor. So engagement, descent. Next is your flexion. So when the head flexes, a well flexed head will present a smaller diameter to the pelvic cavity. Suppose the head deflexes or extends, this diameter will come as the presenting diameter. That is very big. So flexion promotes a smaller diameter, and hence you find that the chin, which comes in contact with the baby's chest, that brings about a nice flexion and a smaller diameter. So when the chin comes in contact with the thorax, that is a well flexed head. The occipito-frontal diameter, which was there before, it changes to suboccipito-bregmatic. So this is the smallest diameter, 9.4 centimeters. Suboccipito-bregmatic. This is the presenting diameter. If it was deflexed, it would have been occipito-frontal. You can see that there's a bigger diameter. It's 11 centimeters. So once there's a well flexed head, the smallest diameter is coming in. Now it has come down up till the ischial spines. You can see here is the ischial spines. Now below the ischial spines, what is happening is the shape of the pelvis is changing. So below this, the shape of the pelvis is such that it's anteroposteriorly long, transversely it is narrow. So if the baby has to come down, the larger diameter has to come into the anteroposterior diameter. So if it has to happen, it has to undergo what is called internal rotation. So by internal rotation, that is the head turns 3/4. The diameter of engagement from transverse or oblique changes to anteroposterior dimension. So you can see the head has come into the anteroposterior dimension. It has rotated and come into the anteroposterior dimension. Now, once the head has come into the anteroposterior dimension, all it has to do is extend its head. If you extend the head, it was well flexed. Initially, it was well flexed inside. Now, if it extends its head, it will come out of the vaginal cavity or the pelvic cavity. So how is it coming out? One is the force of uterine contraction. From above, the force of uterine contraction is forcing it up. The other is below, the elastic resistance of the pelvic floor. The pelvic floor here is preventing it from flexing. So the two together cause the head to come out with extension movement. So head comes out by extension. Now you remember that previous step, they underwent internal rotation. So the head underwent internal rotation, but not the rest of the body. So on the neck, there was a twist. That internal rotation brought about a twist. So that twist remains until the baby has come out. Once the baby's head comes out, the baby's neck is obviously going to untwist. And this is called restitution. So the neck gets untwisted and head restitutes back 45 degrees to have the same normal relationship in relation to its shoulders and original position in which it got engaged. So this is called restitution. So engagement, descent, flexion. You can see that engagement, descent, flexion, internal rotation, extension, and restitution. Now, once the restitution is occurred, now what is left inside is the shoulders. So the shoulders have to come out. Now, if the shoulders have to come out, the shoulders are also in the oblique dimension. So if they have to come out, they also have to align themselves in the anteroposterior direction. So that means the shoulders have to rotate. The shoulders will rotate internally from their oblique direction to the anteroposterior direction. But since the head is attached to the shoulders, any rotation of the shoulder will be transmitted to rotation of the head. So externally, what we are seeing is the baby's head. So we find that there is external rotation of the shoulders, or rather, sorry, external rotation of the head, which implies internal rotation of the shoulders. So the internal rotation of shoulders with external rotation of the head is the continuous because of the continuum of the body. Now, because of this, the shoulders come into the anteroposterior direction. Now, if the shoulder has to come out, either the posterior or anterior shoulder has to come out first. If the posterior shoulder has to come out first, there has to be a lateroflexion. Anteriorly, this has to bend. So there is lateroflexion of the spine. So the posterior shoulder comes out first by expulsion, followed by the anterior shoulder. So the lower one, that is the posterior shoulder, will come out, then the anterior shoulder. And why will this happen? The spine bends. When the spine undergoes flexion, the posterior shoulder comes out. And once it comes out and the hand has come out, the anterior shoulder is brought out. So after the shoulders have come out, the rest of the body, what is left inside? Just the little, very thin abdomen and the small lower parts of the legs. So they will just come out automatically. They don't need big mechanism because they're very narrow. After expulsion of the shoulders, the fetal body will slip down through the pelvic cavity. So the whole process is called mechanism of labor. Engagement, descent, flexion, internal rotation, extension, restitution and external rotation of the head, which is internal rotation of the shoulders, followed by lateral flexion of the spine to bring the posterior shoulder out first, followed by anterior shoulder. So this whole process takes place about 1 to 2 hours in a primary and half an hour to 1 hour in a multi. As I told you, in the multi, it always takes more time because there will be, they are doing it for the first time and there is more resistance. However, once they have done it, or in a case of a multi, they become more used to it, so it will become very fast. Now, once the baby is out, what is left inside? It is the placenta. So the placenta with the umbilical cord has left inside. The baby has been separated. You had put 2 clamps on the cord and you cut in between. You separated the baby. You handed over the baby to the pediatrician. Now, that is the end of the second stage. You are left with whatever is inside. That is your placenta with cord. So in the third stage of labor, this structures also have to come out. So from the delivery of the baby to the expulsion of the placenta is what happens in the third stage of labor. So you can see here the placenta with cord is hanging in the third stage of beginning of the third stage. Now what has to happen for the placenta to come out? So when the placenta is attached to the uterine wall through vessels communicating between the wall of the uterus and the placenta. Now if they have to get separated, the placenta cannot contract. It's not a contractile structure. But the uterus can contract. The moment the uterus realizes that there is something else still left inside, it will start contracting. So you will find that there is contraction of the uterus. So the placenta and the uterine wall are attached to each other. The uterus will contract, but not the placenta which is attached. So what happens between the two? There is a shearing force. And because of the shearing force, the placenta begins to separate. And what happens when the placenta separates? The vessels between the two are cut and they start bleeding. So initially there will be a fresh bout of bleeding. And the blood which collects between the uterine wall and the placenta causes the uterine wall to appear as if it's at a higher level, or the rise in the uterine height. When all of the placenta separates, more and more separation occurs and the whole of the placenta separates. What happens? There can be no more communication between the placenta and the uterus. The placenta will fall down. Where will it fall? Into the lower uterine segment of the uterus. So in the lower uterine segment, it will fall, and on the patient, it appears as if there is a suprapubic bulge. When the patient is lying, it's just like just above the pubic symphysis, there's a bulge. And whatever is attached to the placenta will come further lower down. So what is it? It is giving an appearance of a enlarged, or rather, there is a growing of the cord, as if there is a false sense of growth in the cord. Actually, it is not that. It is just an apparent lengthening of the cord. So to think of all the things that are occurring in this stage, there is a characteristic uterine contractions, again, which starts the separation of the placenta, the expulsion of the placenta, and the control of hemorrhage with permanent contraction and retraction of the uterus. So what are the signs of placental separation? First, the fresh bout of bleeding. Then there's a rise in fundal height, a suprapubic bulge because the placenta falls in the lower uterine segment, and an apparent lengthening of the cord. Now, once all this occurs, you know placenta has separated. It is lying in the lower part of the uterus. It is just separated and it is just here. So all you need to do is pull on the cord and it comes out. So that is what we call active management of labor in the third stage of labor, where you would like to pull on the placental cord, but at the same time you're worried that maybe the cord is the placenta is still attached. If you were to pull while the placenta is still attached by mistake, what will happen? Along with the cord, the placenta, this uterine wall will also invert out and it will come out. So you will be able to see the inside of the uterus, what is called inversion of the uterus. But that's an absolute emergency. It is a catastrophe. It is hemorrhage which causes sudden shock in the patient. It's a neurogenic shock. So you should be very careful never to pull unless you are sure about the separation. So to avoid this, what you can do is what is called a traction, counter traction. You pull on the cord by traction, but also apply pressure on the uterus to push it up. That's called counter traction. Traction, counter traction. I'm just showing that so that you know that when you're pulling on the placenta, on the cord, you make sure that the uterus is not getting inverted. Now, the mechanism of separation of this placenta from the wall of the uterus is two types. One is where it separates from the edge. One edge of the placenta first separates and slowly the bleeding continues all over the placenta and the whole of it separates. But the first separation occurs on one edge. So what is coming out first is the on the maternal surface. This maternal surface of the placenta is seen first. And you know that the maternal surface has cotyledons which look very ugly. So you call it a dirty Duncan's. It was described by Duncan, and just an easy way to remember dirty surface, the Duncan surface. So dirty Duncan is where there is a separation from the edge of the placenta. In the second type, there is a central separation. So the placenta is like this. The center of the placenta separates from the uterine wall. So there will be a collection of hematoma above it. So the placenta forms like a cup. And what is the surface which is coming out? The fetal surface. This fetal surface comes out first. And that is very shiny because it's covered with membranes, the amnion and chorion. So the shiny wall coming out first is what we described as Schultz. So just an easy way to remember shiny Schultz. So dirty Duncan's and shiny Schultz just are mnemonics to remember. So when the Duncan's method is involved, the placenta will fold on itself so that the long axis of the placenta corresponds to the long axis of the uterus. And the edge first coming out is the maternal surface of the placenta. In the Schultz method, the placenta is separating at its center, inwards out like a cup, and the retroplacental hematoma collects, and it leads to complete separation of the placenta with each contraction. Okay. Now, how long does the whole thing take place? It takes place just a few minutes to 15 minutes in both primies and multis. It's a small or a short procedure. Right. Now, what is the fourth stage? In the third stage, now placenta and the cord has also come out. You are left with nothing inside the uterus. So what will come out in the fourth stage? Nothing is left. So this is the most important phase, I would say personally, because this is the time when the open sinuses, the placenta has separated. So vessels which were coming from the placenta, from the uterine wall into the placenta, they're all open. So that has to get closed. That has to stop bleeding. Otherwise, the whole of those vessels will go on bleeding. And in fact, for pregnancy, the body has adapted in such a way that the vascularity is extremely high in the uterus, very high flow for the sake of maintaining the baby. So if the placental vessels don't close, there will be acute hemorrhage and the patient can actually lose their life. So the nature's process is such that after the delivery of the baby and the placenta, the uterus will secure its own hemostasis, which occurs in the fourth stage. Whether it is occurring properly or not, you need to observe. So 1 hour after the delivery of the placenta is called fourth stage. It begins at the end of the placenta to 1 hour later, and it is the stage of sorry, I think there's some little mistake here. I will just change that. From the end of the delivery of the placenta to the 1 hour later, it includes the stage of observation and hemostasis. So how is that hemostasis brought about? So there are 4 methods of hemostasis. One most important one is strong uterine contraction. You all know that the uterine musculature is arranged in the form of crisscross fibers. There are crisscross fibers. So any vessel which is passing through it, like you can see here, so that whenever there is a contraction of the muscle, it gets compressed. It will crush the vessel, or rather it will press the vessel, and there will be no bleeding. So a strong uterine contraction serves as living ligatures, and that brings about a very good hemostasis. The next thing is spontaneous vasospasm. Every vessel, whenever it is injured by whatever reason, it goes into spasm. A simple reason that every vessel has smooth muscles inside its walls. So that causes a very strong contraction as a defense mechanism itself. The third very important thing is formation of platelet plugs, the coagulation cascade. You know that whenever there is any injury anywhere in the body, immediately though we bleed, after some time the bleeding stops. Now how does this occur? The coagulation system in the body will get stimulated. You have what is called the intrinsic pathway, the eccentric pathway. So whenever there's bleeding, this message goes to those centers and it stimulates the pathways, and because of a lot of those procoagulants getting converted into active forms, they stimulate the formation of fibrinogen to fibrin and platelet plugs, which block the open end of the vessels. So the third most important method of hemostasis is platelet plug formation because of the coagulation cascade. So we had a very strong uterine contraction, you had spontaneous vasospasm, you had a coagulation system causing formation of platelet plugs. Now, the fourth thing of what is very important is the opposition of the uterine walls. The walls of the uterus will strongly oppose each other. Now, suppose the uterus remains like a big cavity. What will happen? The blood will go on collecting inside the cavity. But however, if it is strongly opposed, there is no place at all. There is no way for the bleeding to collect. So that is very important, opposition of the uterine walls. That is why we are very particular that at the end of the third stage, when the placenta comes out, you must check the placenta and make sure every bit of the placenta has come out. If even a small bit of placenta is left behind inside the uterus, We call it retained placenta. It does not allow the walls to oppose each other. So what will happen then? There's a small cavity and the blood goes on pouring into this cavity. That is the importance of every bit of tissue that should come out of the uterus at the end of delivery. So just to recollect, the 4 methods of hemostasis are strong uterine contraction leading to formation of living ligatures and constricting the vessels. Secondly, spontaneous vasospasm because of smooth muscle fibers in the walls of the vessel itself. Thirdly, formation of platelet plugs by the coagulation system. And lastly, the opposition of uterine walls, giving no place for the blood to collect. So that marks the end of the 4th stage of labor, where you have observed the patient. You're sitting by the side, monitoring the vitals of the patient, observing whether the uterus is contracted, examining in the vulval side whether there is any bleeding. So those are the things which you do in the 4th stage of labor. Simple observation. And that puts an end of the stages of labor, and you can actually send the patient back into the ward because she has nicely secured hemostasis. There is no more bleeding. And ideally in the 4th stage of labor, if she was given an episiotomy, you would be suturing the episiotomy. And once the episiotomy is sutured, there's no bleeding, you can transfer the patient to the ward. So I think that summarizes all the stages of labor. So I think that should. So all of you must go through these 4 stages of labor. Every one of you has to know these stages. There is no doubt on this that it's going to be asked for every one of you as in some part of the exam. So please go through this, read from the textbook, make your own notes, and be thorough on this part. So mechanism and stages of labor. I think this has repeatedly been taught to you, but however, I would insist that all of you must know this chapter very well. Any doubts on this, please put it to me in the group. If there's anything that you want to know, I can get back to on that if there is any doubt. Thank you.